Liver function. So liver physiology. So the liver plays a crucial role in excreting bile, which is essential for digestion and elimination of certain waste products. Bile composition includes the bile acids and bile salts, bilirubin esters, and cholesterol. For bilirubin metabolism, bilirubin is primarily a breakdown product of hemoglobin. About 80% of that bilirubin is that. The remaining 20% of bilirubin comes from the breakdown of other heme-containing proteins like myoglobin, cytochromes, and catalase. After hemoglobin breakdown, iron is recycled for reuse by your body. Transport of bilirubin. So bilirubin is water insoluble and is transported in the bloodstream bound to albumin, which is a plasma protein. This complex travels to the liver, where bilirubin is processed for excretion via the bile. Once bilirubin and albumin complex reaches the liver, bilirubin enters the hepatic cells. Inside the liver cells, bilirubin undergoes conjugation by the enzyme uridyl diphosphate glucuronyl transferase. This conjugation converts bilirubin into bilirubin diglucuronide, also known as conjugated bilirubin. This form is water soluble, allowing it to be excreted into bile. Conjugated bilirubin is secreted into the bile and enters the intestine. In the intestine, it is converted by bacteria into urobilin, which is colorless. Urobilin is then further broken down to urobilin, which is a red-brown in color, and that's responsible for the color of your stool. Some urobilin is absorbed back into the bloodstream and filtered by the kidneys and then excreted in the urine. A healthy liver excretes 200 to 300 milligrams of bilirubin per day. In normal serum, bilirubin concentration is low, with the majority being unconjugated bilirubin, also known as indirect bilirubin. Jaundice and icterus. So jaundice is the clinical condition which is characterized by the yellowing of the skin and the sclera of the eyes. This occurs due to an increase in the serum bilirubin levels. Icterus refers to the yellow discoloration of blood specimens caused by elevated bilirubin. The liver plays a vital role in numerous metabolic processes essential for maintaining the body's homeostasis. So the synthesis of the proteins, carbohydrates, and lipids, the liver is responsible for producing many plasma proteins, including albumin and clotting factors. It participates in carbohydrate metabolism by regulating blood glucose through glycogen storage and gluconeogenesis. Lipid metabolism includes the synthesis and breakdown of fatty acids, triglycerides, and cholesterol, and lipoproteins. Formation of ketones. So during periods of fasting or carbohydrate restriction, the liver synthesizes ketone bodies from fatty acids, providing an alternative energy source for the body. Storage site. The liver stores significant amount of vitamins A, D, E, and K, which are all crucial for various bodily functions. And then we also have detoxification. The liver metabolizes and detoxifies various endogenous substances and external toxins like drugs and alcohol, ensuring harmful compounds are eliminated from the body. So back to jaundice. Jaundice can be classified into 3 types based on the underlying cause, whether it's prehepatic, hepatic, or posthepatic. So prehepatic jaundice is caused by an excessive amount of bilirubin produced, overwhelming the liver's ability to conjugate it. Commonly seen in conditions like hemolytic anemia, where there is an increased breakdown of red blood cells. This leads to an increase in unconjugated or indirect bilirubin in the blood. In prehepatic jaundice, there is no bilirubin present in the urine because unconjugated bilirubin is not soluble and cannot be excreted by the kidneys. Hepatic jaundice, it results from impaired bilirubin processing by the liver cells. Some causes include defective uptake of bilirubin by the hepatocytes, defective conjugation due to enzyme deficiencies, or abnormal secretion of conjugated bilirubin into bile. So both conjugated and unconjugated bilirubin levels may be elevated depending on the specific liver dysfunction. Now we have post-hepatic jaundice. We have genetic and metabolic syndromes that can affect the bilirubin processing. First one is Gilbert syndrome. It is characterized by the impaired cellular uptake of bilirubin by the liver. This causes mild unconjugated hyperbilirubinemia and is generally benign. And then we have Crigler-Najjar syndrome. We have type 1 of this. It's a complete absence of the enzyme UDP glucuronoltransferase, leading to severe unconjugated hyperbilirubinemia. And type 2, which is partial deficiency of the UDPGT enzyme, causing a milder form. And we also have Dubin-Johnson syndrome and Roeder syndrome. Both are disorders causing conjugated hyperbilirubinemia. The liver conjugates bilirubin normally, but there is an impaired secretion or transport of conjugated bilirubin into the bile ducts. So posthepatic or obstructive jaundice is caused by impaired excretion of bilirubin due to obstruction of bile flow into the intestines. Common causes include gallstones or tumors that are blocking the bile ducts. This results in an increase in serum conjugated bilirubin as it leaks back into the bloodstream. All right, jaundice. We already mentioned this, but we'll do it again. Jaundice is the yellowing of the skin and sclera of the whites of the eyes, which is caused by hyperbilirubinemia, which is elevated levels of bilirubin in the blood. Jaundice can happen in infants as well. So in newborns, high bilirubin levels can lead to kernicterus, which is the accumulation of bilirubin in the brain. Kernicterus is a very serious condition that can cause irreversible brain damage and mental retardation. So prompt diagnosis and treatment are essential to prevent that outcome. Causes of jaundice: the majority of jaundice cases are due to liver disorders that impair bilirubin metabolism or excretion. However, jaundice can also arise from increased breakdown of red blood cells or hemolysis in individuals with a normal liver function. So for an example, transfusion reactions can cause hemolysis, leading to elevated unconjugated bilirubin and jaundice. Cirrhosis, it refers to irreversible scarring of the liver. It results from chronic liver damage and leads to loss of normal liver function. Common causes are alcohol abuse, hemochromatosis, which is iron overload, primary biliary cirrhosis, which is an autoimmune disease affecting the bile ducts. We also have liver tumors, which is a primary liver tumor are a significant cause of cancer-related mortality. The liver is also a frequent site for secondary tumors, which spread from cancers of other organs, so they metastasize to the liver. Ray's syndrome, it's rare but serious condition, is characterized by hepatic destruction following viral infection and aspirin use, especially in children. Patients exhibit abnormal liver function tests, but bilirubin levels often remain normal. So early recognition and management are also crucial for that. Liver toxicity from ethanol or alcohol and acetaminophen. So ethanol, which is also known as alcohol, is toxic to the liver and is a major cause of liver damage worldwide. Chronic alcohol consumption can lead to cirrhosis, which again is the irreversible scarring of liver tissue. Acetaminophen is a common over-the-counter pain reliever. It is also toxic to the liver when taken in excessive doses. An overdose can cause acute liver failure and requires immediate medical intervention. So the analysis of bilirubin, the first method to determine bilirubin levels was developed by Malloy and Evelyn. This technique used alcohol as an accelerator for the coupling reaction between bilirubin and diazotized sulfolinic acid. The reaction forms a colored azo compound that can be measured spectrophotometrically. Later, Jendrasik and Groff improved the method by using caffeine benzoate acetate as an accelerator for the azo coupling reaction. This modification enhanced the sensitivity and accuracy of the bilirubin assay. So there are different types of bilirubin detection. So you have the direct or the conjugated bilirubin. This produces a color reaction in an aqueous solution without the need for accelerators. And you also have indirect, which is the unconjugated bilirubin, which requires the addition of alcohol or an accelerator to produce the color, as it is not water soluble. Direct bilirubin, as I mentioned before, is conjugated bilirubin. It is water-soluble form of bilirubin that reacts directly in aqueous solution during testing. Indirect, also known as unconjugated, is water-insoluble form that requires an acylator like alcohol to react in the assay. So some interferencing substances for bilirubin testing, turbidity or cloudiness of the sample can affect the light absorbance, which can lead to an inaccurate result. Hemolysis, which is the breakdown of the red blood cells, releases hemoglobin, which can interfere with the colorimetric assay. Yellow lipochrome pigments naturally present in serum may also interfere by adding a background color. The Gendrasik Groff bilirubin assay, so the step-by-step process here. So we got specimen preparations. Serum specimen is first added to a solution containing the sodium acetate and caffeine sodium benzoate. These chemicals act as accelerators, improving the reaction efficiency between the bilirubin and the diazo reagent. The diazo reagent is the treated specimen is then mixed with the diazotized sulfolinic acid. This results in the formation of a purple azobilirubin complex. Color stabilization, a tartrate solution is added next to convert the purple azobilirubin to a blue azobilirubin complex. The measurement of this is the intensity of the blue color is measured spectrophotometrically at 600 nanometers. The absorbance correlates with the bilirubin concentration in the sample. Specimen collection. So use a fasting blood specimen to minimize variability, not always needed, but some places would recommend it. The sample should be free from hemolysis and lipemia, as these can interfere with test accuracy. Store specimens in the dark prior to testing to prevent bilirubin degradation. Test the sample as soon as possible after collection. Also note that bilirubin is light sensitive, so exposure to fluorescent and indirect direct sunlight can cause bilirubin levels to decrease due to the photodegradation. And then also know there are two different reference ranges. So we have total bilirubin at 0.2 to 1, and direct bilirubin is 0 to 0.2.